much. Again, good evening, everyone. We have a very loaded discussion or topic that we need to get through in this next few minutes. And essentially, I think that Dr. Magula hit the nail on the head when he said it's a global concern. And in the last 3 years, I think we all have been faced with challenges, not only just because of the pandemic, but more particularly when it came to pregnant women. And many people referred then to the obstetricians to say, how do we manage this? And we were learning as things went along the way. So essentially, I would like to say that I don't have any disclosures, and I'm extremely privileged and honored to have been invited to share my experiences on the clinical care platform. So thank you very much. You've done great work over the last few years, and congratulations for being such an open website and platform for where young minds and those passionate about saving lives, particularly women in particular, can gain confidence. So essentially, we are looking at maternal sepsis, which is the leading cause of maternal morbidity and mortality, and that is across the world. So it's not unique to high-income countries, it's not unique to low-income countries. We all suffer through it together. And it just becomes a discrepancy in terms of the resources we have available for early recognition and management. Pregnant women may be more susceptible to rapid deterioration of illness. Physiological changes can often mimic some signs and symptoms, and this can lead to a delay in diagnosis as well as optimal management. And then there are bedside skills and scores that could aid us with the timeless reduction in morbidity and mortality. And then a huge controversy when it comes to the pregnancy platform and to our cohort of patients is that we often not included in research and clinical trials. And so women who are in the perineum, who are breastfeeding, those who are still pregnant, need to be included in some of this research. And it's very difficult when we look at ethical considerations and attaining consent, because we don't know the effect these research trials can have on pregnant women and their unborn and born babies. And so it's quite important for us to try and strike a very balanced avenue in which we then can enhance our guidelines and update them as we see fit. So as already mentioned, if we have to look over the last 20 years of the Saving Mothers reports, that have essentially been retrospectively identifying why women die in our country, non-pregnancy related infections has been on the charts. And this has been for a number of years. So if we look at it more closely, we can see that non-pregnancy related infections over the past 20 years is still a problem. And even though we've addressed in 2010 across to 2013, HIV, and viral programs, as well as introducing certain vaccines, this still is the leading cause of maternal deaths in our country. So how is we as practitioners and in a population group that advocates for these women, how can we prevent this from happening? And ultimately, prevention is better than cure. So if we have to look at a host of features, we need to be able to be confident to prevent unplanned pregnancies. And this is where the whole concepts of principles comes in to save women in terms of not having unsafe terminations of pregnancies. So contraception platforms and programs where women can seek that safe termination of pregnancy that's unwanted, opportunistic screening and testing. And this is not particularly only for obstetricians or those working with women from an antenatal care perspective, but working with women in general. So this contraception as well as opportunistic screening should be the goal of every healthcare practitioner on every level of care. So a physician can also offer contraception. A physician can also be the same person to be able to afford a woman an HIV test. And I think it's very important that we are able to empower as many people as possible to protect this very unique group. Vaccination programs are extremely important, and this is extremely pertinent, especially during the pandemic, when there was so much of uncertainty, so much of controversy, so much of just not knowing what was right to do for pregnant women and recently pregnant women. And therefore, ongoing vaccination programs, research, guidelines, enabling and empowering women in their pregnancies to stay safe is so important. And that also then goes across to the placental unit to protect the baby when antibodies have been developed. Prophylaxis and early initiation of medication is extremely important. We are very comfortable with giving antibiotics to patients who undergo cesarean section. And there's research now, if you look through into high-income countries, where they are also affording a certain group of women who have had non-operative vaginal deliveries, and within 3 hours of that delivery, affording them an empiric antibiotic to see if that will reduce the prevalence of puerperal sepsis. And it's something that ongoing research is looking to try and prevent these preventable deaths. Ongoing surveillance of disease profiles, and that's where our HIV programs are very pertinent in terms of looking at viral loads, evaluating CD4 counts, compliance to medication, easy access, and empowering these women to be able to look after diseases that we cannot cure and diseases that ultimately we cannot prevent with the vaccination. And so these elements are quite important. And if we can get these aspects right and continue on this circle of life, there will be many deaths that we can prevent. Knowing our resources are extremely important. If we look for guidelines, our Department of Health has offered us a beautiful guideline from 2019, looking at the prevention of mother-to-child transmission of communicable infections. And I love that this is then in a very simple diagrammatic format for us to understand. There are color codes for them to be imprinted on our minds. And it basically goes and refers to pillars that I think are extremely important under each subsection. And the one again is primary prevention of these transmissible diseases. We know how hard the last 3 years were in terms of social distancing, hand washing, wiping down surfaces, making sure that we had aired out our shoes, our clothes, our objects that we used in at work, stethoscopes, pens, etc., wearing off masks. We know how hard it was for us to walk into volatile areas with full PPE on, visors, head covers. And I think that it's taught us a lot in terms of how the first H in any form of resuscitation is making sure that you approach it safely for yourself and for the patient. So eliminating hazards, I think, is extremely important. Like we would look left and right to pass through or cross the road, like we would put a seatbelt on before we start driving. This should become a knee-jerk response in terms of preventing illnesses for patients who are more vulnerable than the rest of the population. Preventing unintended pregnancies among women who are already diagnosed with transmissible infections, and on the whole, preventing unintended pregnancies so that it cause no further harm to the mother. And then looking at the fetal unit, preventing disease transmission from a woman living with the transmissible disease to an infant. And this common umbrella is essentially when we're looking at those mothers that we can counsel and basically give them the confidence to go on breastfeeding their babies. And then looking after the community, providing appropriate treatment, care, and support to women, their children, partners, and their families. So maternal sepsis is not isolated just to the mom herself, but essentially it can outstretch into the entire community, which we have a responsibility to. And so I think it's extremely important that we know where our resources are so that we can empower this group of patients. If we have to look at previous pandemics, what have we learned and what are we aiming towards? So in the 1918s across to 2013, there was this pandemic, which was caused by H1N1, and that had mutations across the years. And essentially, we noted that influenza was killing pregnant women. And not only did it kill pregnant women, but it also had an impact on their unborn babies with congenital abnormalities, cleft lips, neural tube defects, hydrocephaly, congenital heart defects. So there were multiple effects that this type of virus had. And then the influenza vaccine was introduced in our antenatal care, in our antenatal programs in around 2010, so that every woman, even though she had been vaccinated, would have or have been offered to be revaccinated for influenza in her pregnancy because we knew how lethal it was. And then we started evolving with the SARS-CoV-1 that was apparent in 2002 to 2003. This had a 25% case fatality rate amongst pregnant women, increased miscarriages, intrauterine growth restrictions, and preterm births. And at that point, all we did was barrier precautions, and no vaccinations were reviewed or investigated for this group of women. And then we had the Middle Eastern Respiratory Syndrome, which was very similar to SARS, that was predominant in 2012. And this showed that there was evidence of maternal deaths and also had an impact on babies unborn and newborn. And then we had the Ebola virus that emerged in 2014 to 2016 with the most amount of women in the reproductive age group that succumbed to the disease profile. Until now in 2023, we still haven't been established a vaccination to protect these women, and also ended up with catastrophic hemorrhages for those women who were pregnant. The Zika virus didn't have a massive effect on maternal death and morbidity mortality, but it did have an effect on the fetus. And so that was also a warning in terms of women needing to be aware where they needed to travel and how they traveled. And throughout this entire realm, HIV still remains the #1 contributor to maternal deaths. And even in the last report, which is 20 years odd of Saving Mothers reports, non-pregnancy related infection, HIV and TB, despite having rollout of programs and affording these women with the screening, the testing, and the surveillance with appropriate medication and management, still claims many of our lives. Then we had this evidence that happened in the last 3 years, started with the C and ended with the D, and everything in between was extremely blurred because we were shook. Our entire country, not to mention the entire world, had to deal with this new phenomenon. And it really did disrupt everything we knew about medicine, everything we knew about prevention, everything we knew about maternal health. And it evolved as each of the waves went through. And this was extremely worrying in that time frame. So then we had noted that when COVID had finally reached our shores, that in about April to September, across the first, second, and third waves as they were emerging, we lost quite a few mothers, and our mortality rates for maternal deaths increased by close to 30%. And it was only in September of 2020 that we had actually introduced the concept of vaccinations for women who were pregnant or recently pregnant. Because at that point, we had more information to say that these were not live vaccinations and potentially offered more benefit than any harm. Having said that, I'm sure many of us are waiting to see how this evolves in the next 5 to 20 years. And I'm sure many of us will be telling our grandchildren about this pandemic that we all survived, how catastrophic it was, and what we learned from it. So then we move on to the other concept of pregnancy-related sepsis. And surprisingly or not surprisingly enough, these are preventable maternal deaths. And if we have to look at the top arrows, we can see that pregnancy-related sepsis or infections amount for the third most preventable deaths in that category, just under anesthetic-related deaths and obstetrics hemorrhage. So this brings us to the concept of sepsis. What is sepsis? If a patient has a fever, she's septic. If a patient has a cough, she is septic. If a patient has a lower abdominal pain associated with burning micturition, she is septic. And so I think over the years, it's been very difficult because there haven't been definitions that we can all allude to. And perhaps we may have lost a lot of information along the way because patients weren't defined correctly, or they didn't fit into specific boxes for us to understand the disease process. So what is sepsis? Sepsis is complicated. It essentially attacks your defense system. It then puts the innate and adaptive systems, as well as the complement and coagulation cascades that are in harmony within our bodies, into a frenzy, because there is danger that has been surveillanced. This danger needs to be recognized. There are certain signals that the body then releases. And essentially what happens is that there's a cytokine storm, or the soldiers essentially go to war without recognizing what exactly it is they are fighting. And so therefore you end up having your own soldiers succumb because we are not quite sure what we are fighting. Septic shock is even more ominous because of the pathophysiology that comes along with it. And this essentially what happens is that when the endothelial of all of our cells and blood vessels are being affected, there's a release of further cytokines, there's a release of nitric oxide. Nitric oxide then dilates our vessels, and so we become extremely vasodilated, and then that is known as distributive shock. And what happens with distributive shock in pregnancy is that women who are pregnant already have the physiology that is prone to vasodilation, and therefore when they succumb to distributive shock that is secondary to septic shock, they often can't compensate, and that is why the deterioration is so significant. We then have the concept of cardiomyopathy or failing hearts, and I'm sure if many of you have read through surviving sepsis guidelines, from about 2016, we started looking at the introduction of vasopressor support, helping the myometrium, helping those weak myocytes within the cardiac system to try and squeeze and pump that muscle as hard as they could for a cardiac output. And it's because the actual septic phenomenon and the biological pathways that occur dampen the effect of the heart. Then we have pregnancy, which becomes a huge conundrum amongst all of this chaos that is happening in the background. And essentially, we have these physiological changes to adapt the maternal body and physiology to this growing human being. And what then happens is that the sepsis compromises what has already been established in the pregnancy and prones these women to dampen their compensatory mechanisms. And this becomes very difficult to treat if you do not understand the baseline physiology in pregnancy. And one example of this is the cardiovascular. If we have to look at sepsis, we have the endothelial damage, and as a response to try and clear it, we have an increase in nitric oxide. In pregnancy, the estradiol is already promoting prostaglandins and is promoting nitric oxide to try and smoothen that muscle within the smooth muscle. It relaxes it. And that regulation of the smooth muscle then loses its vascular tone, and then it has vasodilation. And so a normal blood pressure in pregnancy is supposed to be lower. If sepsis is then accompanied with this physiological aspect, then it makes it very difficult for pregnant patients to adapt to abrupt hypotension in response to an infection. And this causes significant organ dysfunction because there's hypoperfusion. And so understanding this and being very vigilant, firstly, to prevent it from happening, and secondly, if it is occurring, how to identify it quickly and treat it effectively. And so there's a cumulative effect in terms of each of the organ systems in pregnancy that essentially is going to render a mom even more vulnerable to the effects of sepsis. And then we need to remember that we're dealing with two patients at once. And so like the endothelium within the maternal body is being affected, we need to also appreciate that although the placenta may form as a shield, there are still membranes that protect this baby. And if those membranes undergo under the sheer forces of the cytokine and the biological cascades that are disrupted by sepsis, then often these babies can also become severely compromised. And so we need to be cognizant of our entire maternal fetal unit. So this then breaks down to what is sepsis. Sepsis is a life-threatening organ dysfunction, and it's due to a dysregulated host response to an infection. Nothing explained this better than COVID. We could not understand why certain pregnant mothers were asymptomatic. We could not understand why certain pregnant mothers came in with only a cough or a sneeze, and some of them ended up in ICU. Some were discharged healthily, undelivered, and some died post-delivery in ICU. So barring having risk factors that could have been underlying, not being able to identify which woman was at a higher risk because of this dysregulated host response was extremely challenging and quite alarming, especially experienced during the pandemic. So we are very used to not being included in definitions. And so the WHO has then in 2017 tried to review to say, how do we make this group a specific entity in terms of diagnosing sepsis. And so they came up with the definition of maternal sepsis, and it's a life-threatening condition defined as an organ dysfunction caused by an infection during pregnancy, delivery, puerperium, and even after a termination. So that is important. Septic shock, pregnant women still allude to the same definition as the normal adult population. Septic shock is when a blood pressure or a mean arterial pressure cannot be maintained more than 65 millimeters of mercury after adequate fluid resuscitation and warrants vasopressor support, and you have a lactate of greater or equal to 2 millimoles per liter. And we'll see how that can be a huge, have a huge impact on pregnant patients. Then we came through with many bedside criteria, many different types of scoring systems. Initially, we used to use SIRS, which essentially was sensitive but very non-specific. It looked at temperatures and heart rates. It looked at white cell counts and respiratory rates. And at that point, we thought, oh, this could be sepsis. And as time evolved, we realized that even if a patient had a temperature of 38, it didn't mean that she had an infection. Perhaps she was having an inflammatory response. And that is why it is so important to understand the evolution of medicine and not to be fixated just on numbers, but to take it holistically and apply it to every patient uniquely. In 2016, they introduced the Q-SOFA, which is the quick sequential organ function assessment. This was to be used out of an ICU setting, so in the ward, in the labor ward, in the maternity admissions, to quickly try and identify if a patient potentially could be septic and if there was any features of organ dysfunction. This looked at a systolic blood pressure, a respiratory rate, and an augmentation. And essentially, then you had to score this out of 3. 0 out of 3 is the preference, but if you had 1, that increased morbidity and mortality by about 3%. And if you had 2 out of 3, it was quite significant, from anything around 10%. Then that also became reviewed, because not everyone who has a respiratory rate of 22 in pregnancy potentially is tachypneic. And so then that got modified to say, okay, let's look at obstetric modified Q-SOFA values. And here we looked at a systolic blood pressure that was less than 90 milligrams of mercury and a slightly higher respiratory rate at about 25 beats breaths per minute, and we maintained with the altered mentation. Having said this, the Q-SOFA can tell you that something is not right, but it doesn't necessarily tell you that this patient is septic. And so what's very important to note is that we need adjuncts. As much as we have these tools to assist us, we need to be able to know how to interpret them and use them holistically. And so essentially, we are working against time. And what we need to be able to evaluate is make sure we have early recognition, take early action or intervention, and you want to try and correct the problem as quickly as possible. And so we have the maternal early warning signs, essentially, which was introduced from about 2008, 2010 in the Saving Mothers guidelines. And essentially what this meant was that we were losing women due to pregnancy-related sepsis, especially in the puerperium. So if any of you have access to the maternity books, you'd be able to open to the postnatal vital signs, and you will be able to see color coding to try and enable us to pick up when there was trouble. And so this is essentially what the chart looks like in terms of knowing when it's normal. When it's amber, you should be cautious. And if there's a red alert or any of the vital signs fall in the red blocks, you know that you need to start looking. You know that you need to start calling for help, and you know you need to evaluate why that vital is falling in the red area. So then the question comes down to probable versus possible. And this can be very frustrating because we want an answer. You want to be able to plug in a formula and get an answer and say this is or this is not sepsis. And unfortunately, it's not as easy as possible, especially because the patient is pregnant. So if we start looking at clues, or if we look at information that can then assist us in terms of how to make this evaluation, we can look at modified SOFA scores, which is the sequential organ function assessment. We look at the large organ systems like respiration, coagulation, liver, cardiovascular, central nervous system, and the renal system. If I had to ask a medical officer that's training through obstetrics and gynecology, or someone who's spending time in the labor ward and the high density unit, this would be very easy to evaluate if you were looking at a pre-eclamptic patient who potentially you were looking at a HELLP syndrome. You very quickly know when the platelets are low, you know when the liver enzymes are elevated, you know when there's a potential renal dysfunction. And so all it means is basically looking at slightly new values and familiarizing yourself with how these are calculated. So a PF ratio takes the PaO2, which is the oxygen that we breathe, and then it saturates in the blood. Then you take your FiO2, which is what you are breathing in. So for any of us at the moment, we are breathing in at 21% or 0.21 fraction of oxygen in atmospheric air. And you want to look at the relationship to say, how much of oxygen, fractionated inspired oxygen, do I need to achieve adequate diffusion of oxygen in my blood? And that's where that ratio comes in. And so you do need a blood gas to be able to facilitate this. And anything greater than 400 means that the patient is well from a respiratory point of view. The patient needs minimal amount of oxygen to be able to saturate the blood. This does not mean the patient is delivering the oxygen to the cells, and this does not mean that the patient is comfortable. So you have to look at your patient. If she's breathing at a respiratory rate of 33, she's heaving, you can see that she's using her accessory muscles, she's on a polymask, and she's maintaining her PF ratio of greater than 400, this is a sick patient. So the amount of oxygen supplementary support she needs to be able to get that value is quite enormous, and she's working very hard to get to it. And so what I'm trying to demonstrate is that, yes, we've got these beautiful tables. Yes, we've got these beautiful figures. They are to aid us in terms of severity of a disease process, but it does not mean it's isolated just to this piece of paper or to this table I'm showing you. Other elements that we can use, like I've already mentioned, is the modified obstetric Q-SOFA score. Then there's an extensive SOS, or the sepsis and obstetric score, where we take in all the parameters that we've spoken about, we plug them into this table, and we take account. And if you score 6 or more, it essentially tells you that your patient does have significant organ deterioration or impending organ deterioration, and often you need to be able to involve a multidisciplinary team and get your patient into a high density unit or into an ICU to monitor these parameters to make sure there's no deterioration. And in the meantime, trying to evaluate why this patient has scored more than 6. These are indications of transfer to the intensive care unit. We are quite competent in the last few years, especially after COVID, to look after many of these patients in the obstetrics high density unit. And so also, again, it depends on what you have available. If you do not have facility to look after a patient who clinically does not look well, call for help. Before we can decide on possibilities and probabilities, we have a high index of suspicion. And I think it's extremely important that we are able to initiate a resuscitation whilst we are trying to solve this puzzle. And so the basic principles that we've learned throughout our medical exposure and throughout our training tells us that we need to maintain that the patient gets oxygen, and we need to deliver this oxygen. And by doing that, we need to make sure the airway is patent. Quite difficult in pregnant patients if they have pharyngeal edema and they have unprotected airways. So we can use mechanisms like the Goodell airway, or we can possibly, to maintain an airway, consider intubation. We need to breathe for our patients with oxygen therapy and support. We offer quite a few of our patients non-invasive ventilation, and we can also offer them high flow oxygen. And these are some of the elements that became even more pertinent during the pandemic. And so we could support for these measures to assist our patients. Circulation is extremely, extremely important, not only for maternal perfusion, but for the placental unit as well. And so maintaining that blood pressure with elements such as intravenous crystalloid fluids and vasopressors is extremely important. And it's quite an art that you would need to try and evaluate at which time you would need that vasopressor. And that is why you need to be at the patient's bedside with the team working with you, so that together we can make good decisions. And so that once concentrating on the breathing is not then also needing to look at circulation, because then your concentration between the two systems can be very blurred, and we want to give this patient the best possible opportunity. Disability, looking at neurological optimization is extremely important. I always teach my medical officers and interns and registrar, there is no such thing as an uncooperative patient. If a patient is confused, or she doesn't understand you, or she's restless in bed, it means that the brain is in trouble. There's not enough oxygen getting into there, or we don't have adequate circulation or cardiac output to get glucose and nutrients for that brain to perfuse. So always make sure that if a patient is not GCS 15 out of 15, what are we missing and how can we optimize on that? And then E essentially is your thorough examination. In resuscitation, we say the E is to extract the uterus. But here, what we need to be able to do is we need to understand what we are looking for, and we need to be very vigilant and look thoroughly. So in the interim of doing this resuscitation, we have a bundle that can be utilized called the 1 hour bundle. And this essentially is saying, please enhance perfusion. If we do not get oxygen to the cells, if we do not remove waste products, membranes are going to break. And when membranes break, there's a release of a whole lot of biological warfare into the blood system that causes this massive cytokine storm. And so these elements are extremely important. Lactate levels can be a surrogate marker for perfusion. We want to try and obtain any form of surveillance that's going to assist us in terms of deciding whether this is probable or possible infection. So obtaining the right blood cultures, trying to perform them before we administer any antimicrobial agents that can dampen that response. We want to administer a broad spectrum antibiotic, and I'll try and assist you to see how we can have a system to do that. We want to begin with trying to improve our blood pressures for cardiac output. And it was suggested that we should be using about 30 mils per kg for hypotension, or if the lactate is greater than 4. And then we looked at the pregnancy population. We said if we did that, we essentially could cause them to complicate with pulmonary edema. And so essentially, the RCOG decided that they were going to put out a statement to say that perhaps we need to consider a smaller volume in pregnant patients who have a lower oncotic pressure. And I think that's relevant, and I think that's very important practice. And then applying vasopressors if hypotension persists, which would be important. This is within your first hour. You have close to 6 hour target to try and correct the pathophysiology and your ABCDs, at which point, if you do not get clearance of the lactate, if you do not improve on the blood pressure, if you do not find the pathology you are working with, then you need to get the patient into a unit that can support her. Do not forget that there are potential sites for puerperal infection. So it's not always isolated to the abdomen. We need to do a thorough head to toe. We need a good secondary survey, detailed history, and a thorough examination throughout the entire body to try and elicit which organ system, if not 1, 2, or 3 in unison, can be causing such a deterioration in our patient. And so in essence, we need appropriate antimicrobials or antimicrobial stewardship and adequate source control. And I'm sure many of you have seen a Caesar that has complicated. Puerperal sepsis occurs quite significantly around the world. About 5.9 million cases are reported in high-income countries for their live births. And that amounts to about 4.4%. If we look at low middle-income countries, that goes up to about 11%. So we can only imagine how many patients complicate from cesarean sections. Considerations in pregnancy and breastfeeding when looking at antimicrobials is extremely important. Risk-benefit ratios, we need to consider teratogenicity, breastfeeding, and resistance. And infections, as we've spoken about, we need to prevent them as best as possible. We do not use the FDA categories regularly. I do like them because I think it explains very nicely how you need to consider giving medication to patients. There's a good website called LACMed that essentially can assist. It's an app that you can get through the App Store, plug in a drug, and it will essentially tell you whether it's safe for a pregnant mom, especially during lactation. These are some of the drugs we try not to use. And if we were using the FDA, you can see the D's mean danger. And those are the multitude of drugs we would not use for patients who are pregnant. There are multiple infections that occur throughout the pregnant body. There can be maternal impacts, placental impacts, fetal impacts. Infections can cross through to the baby. And even if it's not during the pregnancy, it can also still happen at delivery. So we need to be cognizant of horizontal and vertical transmission. Many of us look after patients with preterm labor, rupture of membranes, urinary tract infections, lung infections such as COVID, influenza, pulmonary TB, PCP, HIV. All of these need to be ruled out or excluded in a patient who potentially scores significantly when looking for sepsis. And so antimicrobial stewardship has many steps. The first is very important, and this is the IPC care and measures that have to happen within your healthcare facility. And this essentially is prevention. So it's very important that we wear masks when needed, we wear gloves, we use barrier mechanisms such as an apron before examining a patient, we wash our hands afterwards, we understand what we are washing our hands with. For example, if we're using antiseptic hand rub that has chlorhexidine and 70% of alcohol, you need at least 5 ml of fluid in your hands to be able to clear it of microbes. Then we look at community-acquired or hospital-acquired infections. Antibiograms are patterns of resistance that each microbiology department and IPC clinical teams can present or investigate within a healthcare facility. We get our antibiogram emailed to us every Friday for the week to try and pick up which ward has a resistant bug. And so we know what movement around the hospital is. Broad spectrum antibiotics, and we want to try and get to a definitive antibiotic as soon as possible once we have a culture and sensitivity guide. And then we use something called the Ds, which I learned. Drug, you want narrow spectrum to try and target what you are targeting and to reduce enhancing any form of resistance. You want to consider the pharmaceutical as well as the pharmacodynamic and kinetic principles of pregnancy. You want to look for how long you need to give this medication because it can have effects on the unborn baby. How are you delivering it? Are we giving it IM, intravascularly, intramuscularly, or per os? And trying to de-escalate as soon as possible, not to cause any harm to the maternal fetal unit. Community-acquired infections are often those that are apparent after 48 hours of an admission, and a hospital-acquired infection is apparent after 48 hours of admission or within 3 months of discharge. So if a patient has been in the hospital for a prolonged stay, say, for example, she was admitted for preterm labor, she was tocalized and she did well, and she stayed in the hospital for about 4 days. She was discharged home and she comes back with acute abdominal pain. Need to consider that potentially she had taken something home and had succumbed to that infective process from the hospital. This is what an antibiogram looks like. This is our multi-drug resistant organism list, and this is to highlight where we need to take caution and try to prevent outbreaks within the hospital. So antimicrobial therapy should be initiated within the first hour for septic shock, in the first 3 hours if you suspect sepsis. Empiric anti-infective therapy would be to cover gram-positive, gram-negative, and anaerobic bacteria if they're community-acquired. Consider that hospital-acquired infections may have developed some resistance. Often we do not want to give an empiric antibiotic or antimicrobial for more than 3 to 5 days. By then we need to have culture guidance because we chose the best drug at that time, but it may not be what the organism is susceptible to. And then we want to review daily for de-escalation. So this essentially was taken from the surviving sepsis guidelines, and it looked at the antibiotic timing, when shock is present and when it is not. And it's essentially what I presented to you. But I think it was important because reviews are showing that perhaps we need to be more astute than offering an antibiotic, because sometimes you can have a patient with everything I've told you, barring the clinical examination, and does not need an antibiotic. So knowing definitions and how to arrive at those are extremely important. Biomarkers in pregnancy, we use something called the procalcitonin to guide antibiotic therapy because it can shorten the therapy duration. It's of use in bacterial infections, but not viral infections. And the evidence we have is that it showed benefits in patients who had community-acquired pneumonia, where 6 days antibiotics could be administered to the treatment group and versus the control group that got 10 days of antibiotics. So procalcitonin does not assist you to make a diagnosis of sepsis, but it does guide you to say potentially it could be a bacterial infection. And it is even better to assist you in terms of when you need to de-escalate your antibiotic therapy. So because there was this deficiency in the pregnant population, I'm very proud of one of my inmate students who has passed his master's, looking at correlation of procalcitonin levels, as well as the quick sequential organ assessment score in obstetric patients. And we did this at Barra because that's where he was for, I think, close to 8 months because of COVID. And essentially, we found that there was a significant positive correlation found between PCT and QSOFA scores. So that showed that if we had a patient who had a QSOFA score of 2, then she had a higher PCT. And we are basically now trying to do our secondary analysis to see if this truly was in keeping with sepsis, and potentially having a point of care procalcitonin, a machine available in labor wards and high density units, can assist us with bedside assessment to try and rapidly assess whether pregnant women have sepsis or not. These are common organisms of the purpurium. Streptococcus pyogenes and E. coli are flesh-eating organisms that can essentially kill our patients. They also adapt into multiple resistance patterns. And so for these certain types of bacteria, we may need to consider combination therapy, especially when it comes to Pseudomonas and Streptococcus-like infections. Then you have this element of source control, which is extremely important. I don't think any one of us on the platform today would expect to throw Augmentin at this necrotizing fasciitis, at this flesh-eating bacteria, and expect it to resolve. So these are pictures of patients that have given me permission to take pictures. And essentially, these are patients that came into our facility, referred either from another hospital or one of our own cesarean sections that succumbed. And essentially, what you need here is a brave surgeon. You need to cut out as much of dead tissue as possible to prevent it from spreading. Very often, some of the new registrars and those in training would say, but when would you do a hysterectomy for source control? Because it can be a very loaded decision to remove the concept and the right of fertility from a woman and from a couple. And so have a high index of suspicion. Always do your clinical examination to the best of your ability. And this is, take a detailed history to look for risk factors. Do a thorough clinical examination so that you can pick up which organ system may be affected. Look at your high-risk groups. This green top guideline was done in 2012, so I've added in a few other elements that we would need to consider. I think a pandemic that we've been experiencing, at least in the last 4 weeks, is obesity in pregnancy, where we are operating on patients who have BMIs close to 71. And so difficult surgeries can definitely be a risk factor, and we would need to decide on how we prevent the infection from incisions, where we choose to deliver, who delivers, who's doing the Caesar, how are we closing that abdomen, are we affording prophylactic antibiotics. So if you're not sure, stick to the principles. And this is extremely important because this, you need to be your best Sherlock Holmes. Don't miss a footprint because any information will be able to guide you in terms of what is the best practice for that patient. This is an acronym we often use in the ICU. And essentially, it started off with big laws, and it was to look for, on a daily basis, a bladder infection, intravenous line sepsis. Could there be C. difficile from a gut perspective? Could the patient have a hospital-acquired pneumonia in the lungs? Because the patient's not feeding, and acalculous cholecystitis. We looked at wounds if the patient had surgery, soft tissues like bed sores and sinuses if they are ET tubes, as well as NG tubes in those spaces. Then we added endocarditis, and then I took the liberty of adding the P on the top, which stood for pregnancy related. So features like chorioamnionitis, chronic deciduitis, puerperal sepsis. Be vigilant. So I think I am running out of time, Dr. Magugula. Is it okay if I skip the clinical scenario and then go to the conclusion?
I think please take your time, Prof. We do have at least 15
Yes.
minutes after 7, so you may proceed. I think it's going to be an interesting one. Thank you.
Okay,
Thank
sure, no
you.
problem. I think part of my disclosure would be to say that I get so passionate about the subject that time management is not my best. But please, I know it's some people may need to afford family time. And being a mom myself, if I need to get to the salient points, I'm very happy to do that. So here's a conundrum for you. This was a 19-year-old primigravida who presented to us at 28 weeks. She had normal booking bloods and she was admitted for imminent eclampsia and HELLP syndrome. She then was delivered by cesarean section for an intrauterine fetal death, and she was in a regional care facility close to us. And essentially, she was then kept in hospital and treated for sepsis. The patient had persistent multi-organ dysfunction syndrome. She had severe thrombocytopenia, an acute kidney injury, a liver derangement, and this wavering GCS. She was referred to us after 21 days. At the time, she had complicated in her primary care hospital with status epilepticus requiring ventilation. She also required renal replacement therapy. She needed a correction of disseminated intravascular coagulation. She was awaiting blood cultures that were sent, and we were awaiting imaging studies. Clinically at the bedside, we noted that the patient's Q-SOFA was 2 out of 3. She was extremely jaundiced and she was pale. She had decreased breath sounds on the right chest, and she had cardiac sounds that were normal. The abdomen was tender. There was still one suture that we could examine, and that was appropriate. There was no hepatosplenomegaly, and there were no fluid thrills, and there was no distension. On a pelvic examination, the speculum exam was normal, but on sonar examination, we did note that there was some free fluid in the pouch of Douglas, and there was a small mass that we could see. So this is her radiology. If you can appreciate the chest X-ray, there's a loss of volume on the right lower lobe. The middle lobe seems fine because we can see the heart border. And then if you look at the ultrasound, there's a slight endometrium, which was about 1.46 centimeters, nothing really obvious. And then in the pouch of Douglas, we thought perhaps we saw a clot, or essentially it just didn't look like clear fluid. So this is what evolved in terms of her blood results. She was anemic. I mentioned she was pale. She had an acute kidney injury. She had elevated liver enzymes. She had a D-dimer of 8.4. Her CMP was normal. An autoimmune screen had been done that was negative. Her hepatitis studies in view that she had raised liver enzymes and was jaundiced was negative. Her TSH was 9.67, slightly low. Her ferritin was 2,357, a marker of inflammation. The CRP was 144 and the PCT was 2.56, and she had a lactate of 0.8. So at first glance, knowing that this patient presented with imminent eclampsia and HELLP syndrome, we essentially can review to see that there is acute kidney injury from pre-eclampsia. There is potential liver dysfunction from pre-eclampsia. But what didn't make sense was the fact that the platelets were 444. And so this was a thrombocytosis. We did, in our sub-analysis of the IMMED study, found that patients who had a slightly higher PCT also had pre-eclampsia. So that's something we need to evaluate. And then this patient has got inflammation with a high CRP and a high ferritin, but her lactate is 0.8. Okay, so possible sepsis, probable sepsis. Okay, I leave you to decide. So then we sent off cultures because we weren't sure and we needed more information. The clinical examination wasn't truly obvious. And the lines were sent off, they were negative. The urine was sent off. There was evidence to say that there was bacteria. The urine PCR was elevated. The gene expert was negative. Sputum came back. Remember that opacity we saw on the chest x-ray with the Klebsiella pneumonia, multi-drug resistant organism that was producing an OXA48 enzyme. Relook, the patient went in for a relook laparotomy because we weren't sure about the fluid in the pouch of Douglas. And the tissue that was sent off in the fluid was negative. The pleural fluid, however, did come back saying that there was a gram-negative bacilli, potentially a Klebs pneumonia. And the blood cultures also came back saying that potentially there was a gram-negative bacilli. So what had happened here is when we were doing our acute surveillance, we noted that because the patient had had an intrauterine fetal death, a cesarean section, and also pre-eclampsia with the HELP syndrome, what had happened was that when she went for her relook laparotomy, there was a necrotic classical uterine incision that essentially had complicated, and then she needed source control, so had a hysterectomy. There was a bladder infection. There was no lines that was excluded. There could have been a gut infection because she had distended bowel, but there was no diarrhea. And potentially she could have had a possible hospital-acquired pneumonia or infection being in a facility for 21 days and compromised. So that was an interesting case because there was dual pathology. And what I would like to make you recognize is that you are actually bedside sonography experts when it comes to obstetrics. And using imaging support, if you are not sure, can assist you greatly. These are some of the ultrasounds that we did, some of the surgeries that we had to do post-cesarean section. You'll see the extensive debridement we had to do of the anterior abdominal wall. At the bottom, we look at an ultrasound that may look a bit suspicious in terms of the myometrium. And then if you follow through with the CT scan, you can actually see air in that uterus, which then promotes to essentially decide this patient would need a hysterectomy for source control. If we look at South African data, primary indications for peripartum hysterectomies has been sepsis, which is quite significant over a 5-year period, especially in low socioeconomic countries. We then looked at, across 10 years, critically ill obstetric and gynae patients, and a multitude of them, if they were not septic when they went into ICU, eventually do succumb to multi-organ failure. And so we need to be cognizant of this group of vulnerability. In terms of updates, we've got the Saving Sepsis campaign and international guidelines for the management of sepsis and septic shock. The most recent one came out in 2021, but unfortunately, these are not directed to pregnancy specifically. So we can derive as much information, but then again, we have to uniquely attribute what we learn to our patients specifically. And so the bottom line is, be your best Sherlock Holmes, stay vigilant, have a high index of suspicion, tiniest action, a risk versus benefit ratio for every decision you are going to make. It makes it so much easier when you're dealing with ethical conundrums, and you can actually work through saying, but I'm trying to achieve the best in this patient, and therefore if it gives her a little rash, it should be okay. But don't bounce that off only yourself. Use your companions, your resources, your safe space in terms of getting all the help, assistance, and confirmation that you need. So a recap from the WHO looks at the definitions. Infection and organ dysfunction gives you maternal sepsis. I think we've gone through this quite considerably, and you will have it at your reference. So it's something to always consider, to try and box patients quickly to try and make a difference while you try and then release what Pandora has to offer you. This is the top 10 pearls of recognition, evaluation, and management of maternal sepsis. And because I've been speaking for an hour, I think these 10 points hit home, and it basically discussed everything that we've elaborated on. So I think this is also very good from a reference point of view. And I thank you very much for the time, Dr. Magagula, and I will hand back over to you if anyone needs any clarity or for any questions. Thank you.
Thank you so much, Prof. That was quite an excellent talk, very insightful. We really appreciate, all the slides, very, very clear, academic, but also practical. So yeah, quite an interesting case. I think very complex and very sick woman that you had there, Prof. How is she? Did she survive? Did she make it home?
Yes, absolutely. And she was reunited with her family. Unfortunately, she lost her first baby and won't be able to have any more. So I think it's sepsis when we are that aggressive, basically we look for quantity of life, but it doesn't mean that we've afforded the patient the quality of life. And so ongoing counseling and psychological support is extremely important.
Awesome. Thank you so much, Prof. David, any comments from your side?
Hello, David.
Good evening, Prof. Good to see you.
Nice to see you too. I love when I feel very old, so I'm sure you can't see the gray, but I love
you're looking good.
Our children grow up. So congratulations. It's so good to see you on the platform.
Good to see you too, Prof. You're looking good. What can I add after Prof has spoken, Billy? I think Prof did justice to the topic. Very, very well comprehensive and very informative. I think the take-home message, I think that I would just perhaps want to add is to the colleagues. I think one thing that I picked up, I would just like to say, sadly, we also had a similar case that you just presented, a patient that was kept at the regional hospital, and she was only also sent to us about 10, 15 days later after she's been there. Unfortunately for her, when she came to us, she was very sick. But to put these two cases together, I think it boils down to recognition. And I think that is one of the challenges that I picked up with the colleagues, is that we are failing to recognize sepsis. And perhaps with the use of the modified obstetric Q-SOFA score, I think these are some of the tools that have not really been very, very well adapted. And I would really like to thank you for adding this to the talk. And I hope with the number of people that are on this platform, they'll be able to use this tool, at least to be able to us to recognize and based on the score, be able to early recognize and perhaps start treatment early, or even refer the patients early, rather than keeping the patients in the periphery, especially like you highlighted, for over 21 days. And it can only go down to recognition. And I think that is the most important take-home message, that we must really recognize sepsis. And if we do not recognize sepsis, most of the time it might be too late. And I believe there is a point of no return in sepsis. Once they reach a certain point, most of the time you can do as much as you can, and they do not really do well. I just wanted to help me, Prof, especially to just clear up for us. You have spoken on the hospital-acquired infections, and you have highlighted up to 3 months, if a patient was hospitalized, it will still be considered as a possible hospital-acquired infection. How will you help us to have an idea on, in terms of guiding the choice of antibiotics? Because we know, and I think that's one of the points, we know that for for community-acquired infections, we mostly use it's a broad spectrum, but we use the kind of those still low kind of antibiotics. So how will you guide in terms of the choice of antibiotics? That is one of the questions that I wanted you to highlight. And then the other one is on the septic shock. Once you make a diagnosis of septic shock, we know that the new, you highlighted that the role of giving the IVI fluids. The problem with obstetric patients, especially the patients that septic miscarriage, they come in with a few days of bleeding, and then at the same time they are septic. There tend to be always this confusion, especially among us, the clinicians. Where do we draw the line between hypovolemic shock and septic shock, and how would you help us to approach those patients, especially early when they come, in terms of resuscitation, regarding to giving them fluids? Because here you are dealing with, sometimes a patient comes with an HB of 4, but the patient is also septic. And you would be careful not to give them too much fluids, because most of the time they will end up into pulmonary edema, as you highlighted earlier. So how will you guide, especially the early management, so that we do not get the patients into pulmonary edema? I think with those few comments, Prof, I would like to thank you very much, and I'm looking forward to your answers on this. Thank you very much, Prof.
Okay, so thank you, David, for those questions. I think the first one you asked in terms of hospital-acquired infections is important, because patients do cross-pollinate. So they may have seen me today, they weren't happy with what I offered, or they didn't get better, and then they go to the next facility. So that is a reality that we have. Someone's discharged from hospital X, and then they present to hospital B about 2 weeks later. So what you would need to decide is you need to know the antibiogram of that index hospital. So what I would do, depending on the clinical profile of my patient, is often try and engage with the microbiology team on that side and say, in this ward, what is your most common bacteria? And then I'll know my empiric therapy. What I do if I cannot have that accessible to me is go to my second line therapy. So for example, if someone came in from the community and they were admitted at hospital X, and we chose to use gram-positive, gram-negative, and anaerobic cover in the form of augmentin, okay? And then she was treated for the condition, and then she left, but then she complicates with something else about 3 or 4 weeks later, and she presents to me. Looking at her scoring system, the severity of her organ dysfunction, her clinical examination, I would go to a higher level. So I would then choose something like piperacillin tazobactam, which would be tazocin, right? I would choose tazocin. I would then decide on a clinical profile. Remember, I said you got to look at the gram-positive group, which is the streptococcus, the pyogenes, that group A, flesh-eating, and you've got a gram-negative group, which is your E. coli, that produces enzymes to break down bacteria. So between the two, to balance it, I would then use the piperacillin tazobactam. If I needed added cover for my gram-negative, I could introduce an amikacin or a gentamicin until I've sent through all of my cultures to try and get a sensitivity. I would then use my clinical acumen together with my PCT and look at the patient's response. If she's responding well to my tazocin, I won't change. If then the bacteria comes back and says, actually, it's susceptible to augmentin, that's where my de-escalation principle would come in. So if you are uncertain, and that's why the D for de-escalation is so important, go high. We're not saying give it for a whole week or for a whole 21 days. You've got an hour to try and stabilize physiology in that patient. So if you go one level higher, like you are doing a grade 3 cephalosporin like Rocephin, or you're choosing a more high-powered penicillin with an adjunct like piperacillin, tazobactam, or you're using a first-generation carbapenem, you've got that opportunity in that 24 hours to then de-escalate once you get more information. So that's how I would practice. Essentially, though, you do need to evaluate your patient thoroughly. Does that answer your first question?
Yes, indeed, Prof. Thank you very much for clearing it up. Thank you very much. And I think it's just very important, like you highlighted, you rather go high and you de-escalate. I think that's what I wanted to
Sure. Please don't forget to ask the patient for allergies. You don't want an anaphylactic reaction and septic shock at the same time. So safe practice. Okay, then your second question was the patient who has an ICA, essentially is bled out. So she's got a hypovolemic shock secondary to hemorrhage, and she's got a distributive shock because there's a septic foci. So you are now dealing with the HB of 4, and you need to give your patient fluids because she's hypotensive or hypovolemic shock. So the way I would address this is if you've got two classes of shock, right? One is no volume and the other one is leaky capillaries. So I would do my assessment hand in hand parallel. The only way of responding to a hemoglobin of 4 and hypovolemia is two concepts. Close the tap and fill up the dam with blood. So you've got an HB of 4. Remember, blood can be used as a research tool, and it is more of a colloid. So it will stay in your intravascular volume for longer. So you're going to initiate this patient with 2 large IV lines. You're going to start with your ABCDs, like I've said. You're going to administer a broad spectrum antibiotic. We can use Augmentin here if she's coming in from the community. If you are worried about strep pyogenes, you've examined her, she's got crepitations in the pelvis, or you've noted there's A, or there was an instrumentation for unsafe, you're worried about that, you can use something even more high-powered from a gram-positive point of view. So we have adjuncts like linezolid, we have vancomycin, but generally Augmentin gives you very good gram-positive cover. And then your distributive shock. If you are worried about this patient going into pulmonary edema, this is the type of patient you will introduce your vasopressors very early on. So you've given her that unit of blood should assist you with the 20 moles per kg in a pregnant woman for volume resuscitation. It's also going to enhance your oxygen delivery because it's got hemoglobin. So it's got volume, it's got hemoglobin. And then if you're still worried that this distributive shock is going to be a problem and your volume is an issue, you continue with the blood and then introduce the vasopressor. So this will be where you would introduce early inotropic support in a patient that's got dual pathology and you're worried about leaky capillaries leading to pulmonary edema.
Thank you very much, Prof. I just wanted to, if you can quickly just comment on, is there a role for, we know about the shock index as one of the tools that can help you to guide. Is there a role for using the shock index? We know that it's very much well studied in hemorrhage, and any role in septic shock?
So it's difficult in septic shock because of the hypotension is not due to volume. So your shock index, you're looking at your systolic blood pressure over your heart rate, and that tells you also possible, probable. So if it's greater than 0.8, it's probable that this patient has got a problem that's going to lead into shock. And if it's greater than 1, it's possible the patient is in shock. So your shock index is more for hypovolume. Remember, distributive shock can also give you hypovolume, but it's a different pathophysiology. I think if you're looking at shock specifically, any class, you can use the shock index. Because remember, the response is going to be that you've got a low blood pressure and you're increasing your heart rate to try and enhance your cardiac output and your perfusion. So if you've used that and you understand it and you know that the value of more than 0.8 is a problem, then yes, you can use it as a bedside. The problem is if you then use it and it's less than 0.8 and you say, yeah, okay, but I'm fine. That's unsafe. So you've got to put all your parameters together. If you've got a shock index that comes back at 0.4 because the patient is not, she can't give you a tachycardia because of the myocyte damage from the sepsis, then you're going to get a very lower ratio and you're going to think that that's normal and that this patient is not in doom. And that is why I spoke about the adjuncts, bringing everything together. You cannot use one specific formula or only isolate to one specific examination. You've got to be holistic in each patient that you manage.
Thank you very much. I think back to you, Billy. Thank you very much, Prof.
Thank you so much, David, for those questions. Very, very important and quite practical and relevant for us. So, Prof, there's some other question. I think David has already addressed the issue of the use of the shock index. There's some few questions around the use of antibiotics post-Caesar as well as post-NVD. So the participants basically want to know whether there's evidence for use after Caesar. I suppose you would have given the prophylactic Kevzol before the Caesar. And then whether we should continue after the Caesar. And there was a slide where Prof mentioned the use or actually the studies that are ongoing regarding the use of antibiotics post-NVD, non-operative NVD, what we should be doing. Your thoughts or comments on that, Prof?
So when it comes to prophylaxis at cesarean section, I think it's been well studied that we do need to intervene with any surgical approach to prevent surgical site infections with a prophylactic antibiotic 30 minutes before the incision is done. And we do use the first or second generation cephalosporin. So Kefsol or Kefaloxin is appropriate. That's going to do your general bacteria that are on the skin. Remember, that's not all we're doing to prevent an SSI. You've done your IPC measures. You've walked into theater after you scrubbed. You're wearing a sterile gown, clean gloves, a mask, and a visor. So all of that together is going to prevent an SSI. In terms of continuing antibiotics post a Caesar, you need to risk profile your patient. If this mother was subjected to a prolonged labor, if she had had more than 5 vaginal examinations, if there's prolonged rupture of membranes, if this was a difficult delivery and impacted head, there's evidence to say that there was meconium stained liquor. The mom has got an unsuppressed viral load, a very low CD4 count, she's an uncontrolled diabetic. Those would be the patients potentially you'd want to do extended antibiotics in to prevent an infective process from happening. So again, it can't be standard for every patient. You need to know and risk profile your patient and do the risk benefit adjustment. The one thing we do though with extended prophylaxis, which is giving antibiotics for more than 24 hours, which is generally 3 doses of a penicillin, is in patients who are in theater for more than 3 to 4 hours. So they've bypassed the first half-life of the initiating antibiotic. If they were subject to hypothermia during that time, and if they've had a blood loss of more than 2 liters. Those are patients, general adult group that we would give extended prophylaxis to, which is for 24 hours. We would then surveillance them with the clinical examination, our bedside scoring, as well as routine daily CRP PCTs to look at what those trends offer us, and if indicated, send off cultures to decide on whether we need to de-escalate or then change to a definitive antibiotic if there is a foci of infection.
Thank you so much, Prof. There's so many questions, but I think I'll take one last question before I ask Dr. Mawela to give the closing remarks. So it's a question from Puti. It's regarding the use of inflammatory markers. So he says, is it possible for Prof to give interpretation of inflammatory markers in response to antibiotics in sepsis, the trends and what they mean? I think this is probably linked to that MMed study around PCT, and it's linked to the SOFA score. So your comments on that, please, Prof.
So remember that we've got the white cell count, we've got the CRP and the PCT, right? So those can be daily tests that we do on pregnant patients. So your white cell count is not going to be very valuable because of a surge response when it comes to labor and delivery. And then you've got a CRP. It's also extremely sensitive, but not very specific. So it can go up with anything. So your CRP can go up in a viral infection, bacterial infection. It can go up if you've just had surgery or pain. The PCT biomarker is specific to bacterial infections. So you cannot at a once-off look at them in isolation. You actually have to look at trends. So if you have a CRP that's doing this, it's going up, right? There's ongoing inflammation in this patient, and you need to then use your surveillance to understand, but why? If your PCT is going up, then there's been an introduction of a bacterial foci, okay? But this means that it's septicemia. That means that the bacteria are producing this PCT, and so you need to then consider a source control. If your CRP is doing that, it's still going up, but your PCT is doing this, right? It's stagnant. That means you've got a sealed off collection, like an abscess, or you've got a confined infection only in the uterus. So like that lady we took to theater for a relook because we looked at the fluid that looked a bit suspicious. No one was anticipating taking her for a hysterectomy because the cervix was pink, it was blanching, her PCT wasn't that high. We knew she had a chest infection. And when we went in, we saw isolated infection onto that uterus for necrosis. If all of them are coming down, that means that the inflammation has been subsided. You've adequately addressed whatever's causing this infection, either by your antibiotic stewardship or by your source control. And if the PCT is coming down, it means that whatever bacteria you are attacking, you are using the appropriate antimicrobiome. And so we have PCT that decreases at its peak by 80%. That is where we would use a guide to say, I am safe to de-escalate my antibiotics at that point.
Thank you so much, Prof. I think you've really addressed many of the very important issues around this. We might go on until 12 midnight if we continue with the questioning. And I know Prof is a mother and you want to go back to the little ones. Thank you so much, Prof, for giving us all your time and effort and preparing this excellent talk. Thank you, David, as well. Dr. Mawela, I'll give back to you.
No, thank you, Prof. Billy. Prof, I don't know if you know that I'm going to be the Minister of Health in the next few weeks. Do you have any tips on what's next at the public health level? Do you have some advice for our public health leaders? We know the beautiful PMTCT guidelines and IPC guidelines, but what's next in putting a dent on this problem? Thanks, Prof.
I think it's having access to it, so making more people aware that is available. I think that things are changing at such a fast pace. I mean, a few years ago, no one knew about dolutegravir. When I was training David many years ago as a registrar, we had something called the A, B, and B+ option for HIV. You know, and so things are evolving. I think we need to make it accessible. We need to do campaigns, roadshows to empower, reach out, teach people. You know, education is just so powerful. And I think that if we can do it across every healthcare system, it doesn't mean that only at my level, because I've been studying for so many years, that I am the one that is accountable. I would love to share that knowledge with as many people that want to participate. I was very disappointed when COVID hit and pregnancy was not prioritized for vaccination. And I think that is something we've learned from. I think that pregnant patients should have been a priority group. I don't think that when vaccinations were available in South Africa and we had international guidance to say that it was safe in pregnancy, that they followed the normal cues and they followed the normal age groups and they only got a vaccine if they had a comorbidity. For me, I would have liked our government to have supported our pregnant population a lot stronger. And I don't know who would have then taken the forefront to say, we've got vulnerable groups. How do we advocate for them? And I think the same thing is going to come down with the children. How do we advocate for those children once it's safe for them to get to the vaccine? So I think if we looked at that little circle of life that I showed very early in the beginning, I think that we need to prevent disease. I'm very worried about antibiotic stewardship. I think people are very easily have access to basic things like ampicillin and augmentin, especially in GP practice and at primary healthcare facilities. And if we don't understand that sepsis has so many different facets, we'll eventually get to a resistance within the community. And if we get resistance of bacteria within the community, so help the human race, because there will be no antibiotic to then prevent that from happening. So I think it's very basic principles that we need to institute. But speaking to everyone who stayed on for so long, to the 417 people, one just left, 416. You're here for all the right reasons. So advocate, make your voices heard, and let's empower our mothers, because without them, there is no human race.